So as you may or may not know, as of April 1st, so 3 weeks ago now, there's brand new PMTCT guidelines for prevention of mother-to-childhood transmission of HIV. There were already new guidelines that came out in 2008, but these have superseded those, have had lots of improvements, and a lot of things that have been added, and a lot of clarifications to the old 2008 guidelines, which were a little bit confusing in some areas, and had some problem areas that hopefully are fixed in the new guidelines. So this lecture is really going to be in 2 parts. I used to give it as 2 lectures, but now that we do lots of lectures in one day, I've combined it into 1 lecture. And there's really 2 parts. One, in the first part, is some theory behind the prevention of mother-to-childhood transmission. So why we do what we do. Okay, a little bit of the evidence, a little bit of some of the research studies that have been out there. And hopefully it gives you a background so that when the guidelines change, if there's new things that come out, you'll sort of understand why things are changing, why we do things the way that we do, and what are the best ways to prevent transmission from mother to child, so to prevent vertical transmission. And then the second part of the lecture is the exact 2010 guidelines. And I'm really going to go point by point through the new guidelines. I've essentially taken the guidelines and put them into a lecture form. Okay, so it's going to be a bit dry for the second half. Seems like I'm going to be reading to you a lot of information, and that's because that's exactly what I'm going to be doing. Okay? So that you hear the guidelines. So no one in this room can say, but I don't know the 2010 guidelines. I haven't seen them. I haven't heard them. Well, after this lecture, you can't say that. Okay, and that's the reason that I've designed it this way, because lots of clinics, lots of the counselors, lots of nurses, and even some of the doctors haven't seen the new guidelines, so they don't know about them. So after today, none of you will be in that category. Okay? So you can blame me for anything in the first part of the lecture. Anything in the second part, you can't blame me because I've taken it word for word from the guidelines. Okay? All right, so start off with the background. And again, these are my own slides, my own words. Okay? So I like to start off this session with a case because these are very real. We see these every day. If you're working at a clinic, if you're working at a primary care clinic, then you see pregnant women every single day. And so we have to learn how to treat them, how to best treat them themselves, and also treat their unborn child, and how can we prevent that child from getting HIV. So this is these are very real cases. All of them have come to me either at Don McKenzie Hospital or any of the other hospitals that I visit. Okay? So this one was a 33-week pregnant female. Her CD4 count was 176. She said she was feeling sick on the day of her CD4 count. So she says she doesn't think that that's an accurate CD4 count. So she asks to have it repeated. So she had it repeated that day. And she came back 2 weeks later, and we got the result, and it was 283. Otherwise, her labs were normal. She had no evidence of TB. And staging-wise, she was really just category 1. She had a few lymph nodes that had been there for a while. So what should we do now? Should we repeat the CD4 again to confirm, is it really low? Is it less than 200, or is it now over 250? Should we delay treatment since she's after 34 weeks in pregnancy already? Or should we start HEART with either AZT3TC Stokrin or 3TC-D4T Stokrin? Or if you don't like any of those choices, you could simply call me. So what do you think? Who likes A? Because we have 2 different CD4s. One's high, one's okay, one's low. We should just repeat it again to see what's going on. Who likes that one? All right, nobody likes that one. Who likes B? We should delay treatment because she's already very late in pregnancy. Okay. Who likes C? Who likes D? Who likes none of the above? I didn't see any hands in any of the choices. Well, a few things about this question is this case happened with the old guidelines, and what happened, and I saw lots of these cases, and I got referred a lot of these cases from PMTCT clinics, and what most people did is A. This is what most doctors, what most counselors, and what most nurses did. If they had one CD4 count that was sort of below the guidelines, and then they, for some reason, repeated it, for whatever reason, and it was now high and didn't qualify for treatment, they say, well, let's repeat it again. And so this woman came at 33 weeks, and then she's now 35 weeks. We repeat it again. Now she'll be 37 weeks. And it's likely that she'll deliver by then, or within a week or two after we make our decision. So are we doing anything to prevent that child from getting HIV in that case? Absolutely not. But that's what most people did in similar cases, where they had one CD4 that qualified the woman, and for some reason it was repeated because maybe that one was old, or they didn't have it at the time, or like in this case, the woman said, oh, I don't think that's right, I feel better than that. And so they repeated it again, and now it's too late to really offer her an intervention that's actually going to work, or actually going to provide some impact. So I don't like A at all. B, what about B? So say, you know what, it's already too late in pregnancy. If the child's going to be infected, it's probably already infected. There's really no point in starting ARVs. Anybody agree with that one? Well, that actually, before 2008, that was the South African National Guideline. It said, well, after 34 weeks, you don't initiate women on ARVs. So does that benefit the child in any way? Does that benefit the mother in any way? It doesn't. Does it potentially harm the child? Yes. Does it potentially harm the mother? Yeah. So I don't know why that guideline was in there, but luckily that dropped out in 2008, and again, it's even better now in the 2010 guideline. Okay, so who likes this one? Initiate with AZT, 3TC, and Stokerin. Okay. That would be a fine regimen. Okay, that's not the problem. There's nothing wrong with that. She's past the first trimester. She's even late into the third trimester. So it's really, Stokerin is not a problem for her. This would be a fine regimen. It's just not the guidelines currently in South Africa. Who likes D? Yeah. Well, before the new guidelines, I would say yes, absolutely. That's exactly what I would do. And in this case, when it was before the new guidelines, that's exactly what I did. The new regimen, the new guidelines actually don't recommend D4T. They recommend tenofovir. Now, there's some problems with that, because if you take tenofovir, if you get a bottle of tenofovir yourself, and it comes in a nice little box, you take out the paper that tells you it comes directly from the pharmaceutical company. It tells you how to dose it. It tells you about the risks. It tells you about the benefits. It tells you proper dosing strategies, when to use it, when not to use it. And on that piece of paper, there's a nice big black box. On that big black box, it says, do not use in pregnancy. Now, is that saying it's dangerous in pregnancy? Well, we don't know. That's the thing. This medicine, tenofovir, is one of the newer medicines, and it's not been studied in pregnant women. So might it cause problems in pregnant women? It's possible, but we don't know what they are. And currently, it is the South African guidelines. So if you're going to stick to the rules and stick to the guidelines, then actually none of these would be correct. You would start her on 3TC, tenofovir, and Stokerin, either Stokerin or nevirapine. Okay, and we're going to talk about why that is in this lecture. Okay, so another case. A 30-week-old pregnant woman presents with a written document. This was a handwritten note from another doctor that said her CD4 count was 170 when he checked it. And then it says, please take over in the care of this woman. So when she comes to us, we drew her CD4, and it said 520. She had chronic diarrhea at the time of us seeing her. She had diarrhea for about 6 weeks, been coming on and off. She was losing weight and she's pregnant, so we know that that's a dangerous thing. And she was already pretty wasted. So her weight was already very low for her height, and she was losing weight while pregnant. And we know, of course, when you're pregnant, you should be gaining weight. And she says, well, the reason for that is I went to the traditional healer and I took some Bajani between these CD4 cells. So that's why that CD4 is now high. So what should we do? Should we delay CD treatment until after delivery? Because now her CD4 is high. Okay. Should we enroll her in PMTCT for single-dose nevirapine? Should we initiate her with 3-TCD-4T nevirapine? Should we repeat her CD4 in 4 weeks to see what's going on? One's very low, one's very high. Or should you just phone me because you're not sure what's going on? C. We start her on treatment. Okay. Right. So again, you have to think whatever we do should be benefiting somebody, the mother, the child, or hopefully both of them. So if we do A, if we delay treatment till after delivery, are we benefiting the child? No, we're not. Are we benefiting the mother? Not necessarily. If we enroll her in PMTCT for single-dose nevirapine, are we benefiting the child? Yes, potentially. Are we benefiting the mother? Not necessarily. And should we start her on, if we do C, are we benefiting the child? Yes. Are we benefiting the mother? Yes, we are. So I like C there. What about D? If we repeat the CD4 in 4 weeks, are we helping anybody? No. So why, if her CD4 count is now over 500, why almost everybody agrees? Why do you want to initiate her? Right. Because clinically she's sick, right? Clinically she's sick. She's actually stage 4 if she's wasted. Right? If she's already wasted, that's stage 4. So it doesn't matter what her CD4 count is. It doesn't matter if it's 500 or 700. She's sick. She's losing weight. So I agree. I would start her on treatment, whatever regimen you choose. Okay? So in this case, that's what I did there. Okay, last case, and then we'll get into the meat of the lecture. 36-week pregnant. Her CD4 count is 112. Her baseline labs are normal. She has no evidence of TB. She was screened. Sputum was negative. No signs or symptoms. She's not taking Bactrim at the time. She's pretty late in pregnancy with a low CD4 count. So what should we do? Should we initiate her on treatment and Bactrim, initiate her on treatment without Bactrim, initiate her on a different regimen and Bactrim, or just refer to PMTCT for single-dose nevirapine without Bactrim, or refer to PMTCT for single-dose nevirapine and Bactrim? A. Everybody likes A. So you would start her on Bactrim, but she's pregnant. She's pregnant. You can't take Bactrim when you're pregnant, right? No, you can. But I get phone calls probably once, twice, even 3 times a week about people asking me, Doctor, I have a patient, her CD4 is very low. Can I start her on Bactrim? The answer is yes. Now, is there a risk to the child if you're taking Bactrim? Well, there is. There is a small risk, particularly in the first trimester. But if the mother is taking vitamin supplements, she's taking folate, that reduces that risks of side effects from the Bactrim. And late in the 3rd trimester, is there also a potential risk to the child? Well, there is also, again, potential risk to the child. It can cause high bilirubin levels in the baby. Now, can you treat a high bilirubin level in a baby? You can. You simply put them under phototherapy and it treats them, right? So it's not that dangerous. Could the mother die of PCP pneumonia if you didn't do this? Yeah. Could she get other infections that you're preventing with Bactrim? Yes, she could. And with a very low CD4 count, that's a higher risk than potential interaction with the baby. So you can use Bactrim. Many people do not give Bactrim to pregnant women. I don't understand why. I don't know where it comes from. It's not in the guidelines. It never was in the guidelines not to give it. But many, many times I see pregnant women with very, very low CD4 counts, and they still are not being given Bactrim. And they're told, sometimes some of them have asked and said, oh, I should be taking Bactrim, shouldn't I? And the counselors, the nurses, the doctors say, no, 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 you're pregnant. You can't take Bactrim. So it is important that these women still take Bactrim. Again, we're always weighing the risks and benefits. And if the CD4 is very low, then I think the benefit outweighs the risks. Okay? So yes, although I'm glad that almost everybody in the class got that one correct. Okay, so there's different... HIV affects pregnancy differently. Okay? So how does HIV affect... how does pregnancy affect HIV? Now there's different studies, and they've looked at all different sorts of women. And there's really mixed pictures. There's really not much effect on progression of the disease. So you don't progress your HIV faster in the Western nations. So in developed countries, you don't really see a faster progression to HIV in women who are pregnant. Their CD4 count does commonly decrease compared to when they were not pregnant. But that's thought to be a dilution effect, because now the blood is being diluted not just between the mother, but between the mother and the developing child. So as there is a normal drop in hemoglobin, there's a normal drop in white cell count, there's also a normal drop in your CD4. That doesn't seem to affect the woman as far as progressing, in terms of progressing from HIV to AIDS, however. In other studies, they have shown that there's an acceleration of disease. And that's mostly in developing countries, or in countries where there's a lot of poverty, and particularly countries where there's a lot of malnutrition. So when there is malnutrition involved, then HIV does seem then pregnancy does seem to impact HIV a bit further, and women do progress a bit faster. Okay. So what about looking at it the other way around? Does HIV affect the pregnancy? And the answer to that is yes, it does. Women who have HIV and are pregnant, they have a higher risk of delivering the baby early, so having preterm delivery. There's a higher chance of, when they do deliver, having a small child, so smaller and lower weight children than they should be having. There's also a higher chance of them delivering a child who's stillborn. Higher chance of ectopic pregnancies, of other infections, because a lot of times women are infected during pregnancy. They can become pregnant, can become infected during pregnancy. So there's a risk of getting other infections, particularly other STIs, pneumonias, and even upper respiratory tract infections. There does not appear to be an increased risk in malformation of the child just because of HIV, however. So if we're going to be talking about preventing mother-to-childhood transmission, we need to know, when does transmission occur? Well, in a pregnant woman, it can really occur at 3 different times. It can take place in utero, so when the baby is not even born yet, the child can get HIV. It can take place during delivery, and that's where the majority of the infections occur, when the baby is actually being born. And it can even take place after delivery through breastfeeding. So how many cases are actually going on? Well, the latest statistics released by the World Health Organization come from 2008. And there are about 430,000 HIV infections from mother to child in 2008 alone. Over 90% of these infections were in sub-Saharan Africa. You can see a very small amount of them were in other places. Less than 1,000 in Northern Europe, and less than 100 in Australia and New Zealand. So very, very few cases outside of Africa, where the majority of them are coming from Africa. So and in an untreated breastfeeding population, what percentage will become HIV infected? How many what percentage of the children? Well, the highest rate in a breastfeeding population where there's a lot of mixed feeding going on, the rate can be as high as 45%. So almost half. If you do absolutely nothing, if you're doing everything wrong, then the risk of transmitting to the child is about half, about 45%, so a little less than half. But there's things you can do at each step to drop that risk. And there's things you can do at each step to drop that risk dramatically and almost eliminate it. So, for one, if you don't breastfeed at all, that drops it down to a risk of up to 30% if you're doing absolutely nothing else at all. Okay? We're going to be talking about the next lecture about the risks of formula feeding the child. It's not completely safe, so we're going to talk about that in the next lecture and a little bit at the end of this lecture. So you can see that during pregnancy, there's anywhere from a 5 to 15% chance of passing on the infection. During delivery, the risk is a bit higher, from 10 to 15%. And through breastfeeding, it depends on what is happening. If there's mixed feeding, if you're breastfeeding and giving formula, breastfeeding and giving other supplementary foods, then the risk can be quite high, up to 15% as well. So you see in all three it can be up to 15% if everything is going wrong, which would be up to 45% total. So there's 5 main factors that are involved in transmitting from the mother to the child. Now there's social factors, maternal factors, obstetric factors, fetal factors, and infant factors. And we're going to look at each of them and look at some of the factors involved in each one of those 5 categories. And the reason that we're going to talk about the risk factors is because there's ways that we can eliminate some of them or reduce them dramatically to prevent children from becoming infected. So what are the social factors? Well, if you're unable to implement prevention strategies in an area, in a country, or in a region, well, then you're not going to be able to impact transmission from mother to child. If a mom doesn't know her HIV status, if we're not testing her, well, then we can't offer her any strategies or anything to prevent her from transmitting to the child. Offering counseling and testing in all antenatal clinic attendees should become part of standard practice. And that's a statement directly from the World Health Organization. And it is also part of the South African PMTCT program, which, as you'll see in the new 2010 guidelines, they've actually strengthened that more from saying pregnant women should be offered voluntary counseling and testing to strengthening and testing more women by provider-initiated counseling and testing. So we don't wait till the woman says, please test me since I'm pregnant. We're saying, no, you're pregnant, you need to test for HIV. Okay? And partners' beliefs and feelings about HIV and ARVs. So if a woman is living with a partner who is not supportive, does not support her in taking ARVs, does not support her in her HIV positive status, then it might be difficult for her to take medicines, to take AZT every day if she's going to take dual therapy, or to take ARVs every day if she's going to be on lifelong HAART. So it's going to be maybe difficult for her socially to comply, to take the medicines if there's pressure on her from outside. Okay. There's also maternal factors that are involved. So the risk of transmitting HIV increases dramatically with a lower CD4 count. So the lower the CD4 count that the mother has, the higher the risk in transmitting to the child. If the mother is malnourished, that also increases the risk of transmitting HIV to the child. If she has other STIs, particularly other active STIs, like active herpes lesions at the time of delivery, active syphilis ulcers at the time of delivery, that has very dramatically increased the risk of passing on HIV to the unborn child. And the most important thing that determines whether the child will become infected or not is the viral load in the mother. Now, as you remember from our graph, the viral load becomes high 2 times during HIV infection. It occurs during acute infection, and it occurs late in infection. So it makes sense that women with a low CD4 count have a higher risk in transmitting to the child. Well, it's probably not the CD4 that's contributing, but we know that the CD4 becomes low late in HIV infection, and during that time, the viral load is very high. Another reason that women who are even HIV negative, when they first become pregnant, should be tested throughout their pregnancy. And why is that? Because if they get infected during pregnancy, that means they had acute infection during pregnancy. If they had acute infection during pregnancy, that means they had a very high viral load for some time during that pregnancy. So their risk of passing on to the child increases dramatically. And so this is probably of my slides in the first half of the lecture. I think this is probably the most important one. If you understand this slide, then you understand every single thing we do with PMTCT. And I think this slide explains it all. This slide came from a study that was done in Uganda. And they took, I think it was 1,500 pregnant women. And what they did is they looked at the women's viral load at the time of delivery, and then they looked at the child's HIV status 1 year later. What they found is a very, very, very dramatic response to the viral load at the time of delivery on the risk of that child eventually developing HIV. So if the mother had a high viral load, if it was very high, over 100,000, she had a very high chance, 41% chance of passing HIV onto that child. And that matches what we said is about among the highest chance, right? Up to about 45% chance in transmitting. Well, in these women with high viral loads, their chance almost matched that at 41%. So they had a very high risk of transmitting to the child. Now, if their viral load was a bit lower, between 50,000 and 100,000, well, that dramatically dropped that risk by 10% of passing HIV onto the child to 31%. Now, if we dropped it by a factor of 10, so we could take a 0 off of there, and had the viral load be between 10,000 to 50,000, that dropped the chance by 20%. So only 21% of those women passed HIV onto their child. If the viral load was between 1,000 and 10,000, they had a smaller 17% chance of passing HIV onto the child. And most dramatically, if the viral load was less than 1,000, if the viral load was less than 1,000, so still you can have a little bit of virus, 700, 500, that's still a significant amount of virus floating around in the blood. But look what happened in this case. There was not one single transmission of HIV from the mother to the child. So if the mother has an undetectable viral load at the time of delivery, her chance of passing on HIV to the child is very, very low. And that's what this study showed. So if we can drop the viral load in the pregnant woman, we can dramatically decrease the risk of HIV to the child. So why would I start a woman at 34 weeks on ARVs when most people would say it's too late? She's so late in pregnancy. Well, because I know that in 6 weeks of treatment with HIV, I can take 1 log, or basically take a 0 off of her viral load. So if her viral load at that time was 100,000 at 34 weeks, if we didn't do anything, very high risk of that child getting HIV, right? But with just 6 weeks of treatment, just 6 weeks of ARVs, we can drop that 100,000 to 10,000. And so now we're between about 20% chance of that child getting HIV. So we dropped it by half, just in that short time period. So that's why I would recommend at any point in time, if a woman comes at 38 weeks, I've started women at 39 weeks on ARVs and 38 weeks on ARVs. Because if I can drop that viral load even just a little bit, I know that I can decrease the risk of that child getting HIV. During the delivery itself, during the labor and delivery itself, there are obstetric factors that can increase the risk or even decrease the risk of passing HIV onto the child. And we know that it's during this time, the labor and delivery, that offers the highest risk of the child getting HIV. So if the mother has a prolonged rupture of membrane, so her water has broken and before the child is delivered, if that time is over 4 hours, then that increases the risk of the child getting HIV. If there's intrapartum hemorrhage, so she's bleeding during the delivery, of course, if she's bleeding, then there can be mixing of blood. If her blood mixes with the child's blood, then there's obviously a chance of passing on HIV to the child. If during the delivery that there are invasive obstetric procedures being done, now these are again anything that can induce trauma, anything that induces trauma can allow for mixing of blood during the delivery. So if they do an episiotomy, where you intentionally cut the woman to help the child come through the birth canal, well, this increases the amount of bleeding and of course will increase the risk of the child getting HIV. The procedure of amniocentesis, taking a needle going from outside inside to the amniotic fluid to sample it, that of course can introduce blood into the amniotic fluid and that can pass the HIV on to the child. Invasive fetal monitoring, like scalp monitors, not used in most clinics, or really in any clinic in South Africa, but in some of the referral hospitals can be done. Well, that introduces a little electrode into the baby's scalp before it passes through the birth canal. And of course that can cause trauma to the baby's scalp and bleeding, allowing for mixing of blood and passing on HIV. And again, forceps delivery, again, something that can cause trauma, introduce blood, and increase the risk of passing HIV. So, things that we can do during the obstetric procedure to reduce those risks. Well, if we avoid artificial rupture of membranes, if we don't rupture the membranes artificially, that decreases that amount of time before delivery, and that can reduce the risk. Okay. Minimize interval between rupture of membranes and delivery. Well, that's sometimes difficult to do. It's not always something that can be controlled. We can avoid invasive procedures and instrumental deliveries, but again, sometimes that's not possible for the risk of the child and the risk of the mother. But we can always avoid these two that I've put in red. Routine episiotomy and artificial rupture of membrane are practices that should not be done on HIV-infected women. Now, another obstetric procedure that can be done is a Caesar section, a C-section. A cesarean section decreases the risk of passing on HIV to the child, particularly if it's done before the woman starts in labor. Okay? This is routinely done in most of the world. So HIV-positive women, before they develop labor, they automatically get a cesarean section. And the reason for that is to decrease the risk of passing HIV onto the child. But to be effective, as I said, it must take place before labor and before rupture of membranes. Most of these studies were done in resource-rich countries. Not much has been done in resource-limited countries. And of course, you have to take into account many things, particularly when offering C-sections, is like the health of the woman. The recovery time for the woman who has a C-section is more than for a woman who has a normal vaginal delivery. So if she has 3 other children at home that she must care for, then doing a C-section may not be the right thing for her. This is not yet routine practice in South Africa. The 2008 guidelines, I thought, left a place open where you could do C-sections for HIV-infected women, and that would be your reason for it. The new 2010 guidelines specifically tell you not to perform C-sections for the sole purpose of preventing HIV. If there's other indications, then absolutely you should, but they actually say you should not do a C-section for the sole purpose of that, where in many other countries they do a C-section for the sole purpose of preventing HIV. There are also fetal factors that can influence transmission. So if there's multiple pregnancies, so twins or triplets, well, the first child born actually has, the first child delivered actually has a higher risk than the other subsequent children that are born. So you can have twins, and it's not uncommon to have twins born where one is positive and one is negative. The positive child is usually the first one born. Because the first one born experiences the most trauma. That's why the firstborn, because that's the one that has to open the vaginal canal, and the second one usually scoops right up. So the first one is exposed for a much longer period of time because they're the ones having to go through all the contractions and, of course, the time where there's mixing of blood, where usually the second one is very quick. Prematurity. A premature child also has a higher risk of getting HIV. All right. And, of course, there are infant factors that occurred during breastfeeding. Okay, this is our next talk after this one, where we're going to talk about infant feeding practices. But breastfeeding does offer a risk of transmitting HIV to the child. That risk is dramatically increased if the child is mixed feeding. And by mixed feeding, we mean breastfeeding plus receiving any other sort of nutrition. So be it formula, be it juice, be it soft porridge, be it other complementary foods, that plus breastfeeding is considered mixed feeding. And that offers the highest risk of getting HIV, and as we're going to talk about in the next lecture, it also offers the highest risk of the child dying. Exclusive breastfeeding, we'll talk about that, although there is a risk of getting HIV in the child, it is a pretty low risk if done properly. Oral lesions in the child, if the child has thrush or oral sores while breastfeeding, that increases the risk of the child getting HIV. And again, if the child is premature, that increases the risk of the child getting HIV. So what are some of the interventions we can offer women to prevent transmission to the child? Well, one of the first things, and the WHO says one of the first and most important things we should do, is avoid unwanted pregnancy. Women who are sick with HIV with low CD4 counts, they should not be getting pregnant until they're on ARVs, until their CD4 is higher, and ideally until they have an undetectable viral load. Because if they have an undetectable viral load at the time of conception, then the risk of that child developing HIV is extremely low. It's less than 2%. So you go from 45% all the way down to less than 2%, more likely probably less than 1%. If we offer routine HIV testing, as I said, if a woman doesn't know her HIV status, then we can't offer her an intervention to prevent transmission to the child. ARVs as part of HEART, so ARVs for life to treat the mother, or even short courses like single-dose nevirapine monotherapy or dual therapy with AZT and nevirapine. All of these have been shown to dramatically reduce the risk of the child getting HIV. We can modify obstetric practices to avoid routine episiotomies, avoid artificial rupture of membranes, try not to use forceps deliveries, We can offer C-sections to women who qualify for them. And by modifying infant feeding practices, again, we're going to talk about that in the next lecture. So family planning, as you can see, the top two on that list were parts of family planning. So the first plank of WHO PMTCT recommendations include avoiding unwanted pregnancies in HIV women. If you do that, that obviates other PMTCT interventions. If women who are HIV positive don't want a child, don't become pregnant, then we don't have to offer her PMTCT services. One that is recommended and is quite simple is the use of injectables like Depo-Provera, which are very effective at preventing pregnancy. You have to ask women if they'd like to use this. Many times when women come to the clinic, I ask them if they're on contraception, and they say no, and I ask them if they would like to, and they say yes. And I said, well, why haven't you been before? They said, well, no one ever told me about it. No one ever told me it was possible. They didn't tell me how to do it. They didn't tell me my options. So I think it's a very important part of any visit that a woman comes in, when she's not pregnant, any woman of childbearing age, it's something that we should talk about. Does she want to become pregnant now? Or does she want to avoid becoming pregnant? So if she doesn't want to become pregnant now, then we can offer her some ways, Depo-Provera, oral contraceptive pills, or other things that can prevent her from becoming pregnant. Right. So what about ARVs and transmission? Well, ARVs for maternal-to-child transmission can be really offered in two ways, as I said. One as a maternal treatment program, or as a maternal infant prophylaxis program. ARVs reduce transmission by one way, and as I said, it's the most important way. ARVs decrease the viral load. They decrease the amount of virus in the blood. By decreasing the amount of virus, you decrease the chance of that child getting HIV. The most studied drug for this is AZT. AZT is very safe in pregnancy. It has been used for many, many years in many, many different countries and is shown to be very, very effective. Other things are also well studied and considered safe. AZT, stavudine, nevirapine 3-TC, those are considered the safest. Okay. Stokrin outside the first trimester is an acceptable alternative. Okay. Because the risk of developing a fetus who is malformed on Stokrin is only during the first trimester. Okay? Once the fetus is fully formed after the first trimester, there's no longer a risk of being malformed. So then Stokrin is actually safe. So the current guidelines in South Africa, when do women qualify for life-term HAART? So they're treating not only the unborn child, but also the mother. Well, the new guidelines say that if anybody at stage 4 qualify, and now pregnant women will qualify at a CD4 count of less than 350, regardless of WHO stage, and at any gestation. Okay? At any gestation. Again, the 2006 guidelines said that you cannot start ARVs after 34 weeks. This says at any gestation. If the mother qualifies for treatment, then you start ARVs. Okay. So first line for pregnancy, you actually have multiple choices. The old guidelines said nevirapine, D4T3TC was the mainstay of treatment for pregnant women, although there is quite a bit of a risk of using nevirapine in women with higher CD4 counts. And that is going to take effect now that we have the new guidelines in initiating women with CD4 counts over 250 and 300 and approaching 350. There's a much higher risk of that woman developing liver toxicity if she takes nevirapine. Efavirenz or Stokrin can be used after the first trimester. if we make sure that she's on contraception after she delivers. And as I said, now the new guidelines have replaced D4T or stavudine with tenofovir. So that will become part of first-line treatment for pregnant women. Second-line treatment is unchanged for pregnant women, as the same as everybody else. So AZT, DDI, and Kaletra. So what are the advantages of HAART or ARVs or lifelong HAART during pregnancy? Well, there are very, very low transmission rates when using ARVs. If you use triple therapy, 3 drugs, the risk of the mother transmitting HIV to the child is less than 2%. So you go all the way up from 45% down to less than 2%. This is the reason why pediatric HIV in the United States and in the UK is becoming extinct. There's not very many HIV infections in children coming because the mothers are automatically put on ARVs, regardless of CD4 count, if they are pregnant, to prevent the child from getting HIV infected. The use of multiple medicines, so using 3 drugs, reduces the risk of resistance, as we talked about a few times already, and we're going to talk about again during the resistance lecture. But using 3 drugs reduces the chance of getting resistance to the mother and to the child. HAART should be considered for all pregnant women who qualify for treatment, and now that bar has been raised to a CD4 count of 350. It's most effective if started at least 4 weeks prior to delivery. And that's why the old guideline used to say start before 34 weeks. But does that mean if you started at 38 weeks, it's not effective? No, it's still effective. You're still lowering the viral load and decreasing the risk to the child. Okay. So at any gestational age, it is safe to start HAART. Okay. So compared to no therapy at all, so compared to nothing, of course, HAART offers no additional risk of the complications of pregnancy, like low birth weight, low APGAR scores, or stillbirth. There's a possible association with the use of protease inhibitor-containing regimens and increase of developing a very low birth weight child. But you also must think about which women are taking protease inhibitors, usually as part of second-line treatment, and usually women who are already pretty sick. So that may not actually be the case. Okay? Efavirenz is potentially teratogenic, so it can cause birth defects in the child, and should not be used in the first trimester. So if you do have a woman who comes during the first trimester, you should avoid using efavirenz and use nevirapine instead. It's important not to use D4T and DDI together during pregnancy because the risk of toxicity, the risk of side effects, particularly lactic acidosis, is very, very, very high in pregnant women. Both of these medicines increase that risk, and if you take them together, that risk is dramatically increased. Okay. So regimens for women who become pregnant on ARVs. So if they're already on nevirapine 3-TC-D4T, you can continue that regimen. If they're on Stokran 3-TC and D4T and it's in the first trimester, then you could switch them to nevirapine. If it's after the first trimester, they can simply continue their treatment. If they're on AZT, DDI, Kaletra, then again they continue their treatment. In all of these women, we should be monitoring their liver function tests. In women who are on Kaletra, we should also be monitoring their blood sugar, and women who are on AZT, we need to monitor their FBC as we would any pregnant woman. So prophylaxis, so basically using single-dose nevirapine or using dual therapy. Does this treat the mother? So the current guidelines for women who have a CD4 count over 350 is to take AZT starting at 14 weeks. Is that treating the mother? No, it's not. It's treating the baby, the unborn child. Is it potentially harming the mother? Some say yes, some say no. Those of you that say it's harming the mother, how's it harming her? She could develop resistance, right? What did we say? You need 3 drugs to prevent resistance. But we're giving her 1 drug. If she takes 1 drug for at most 7 months, 8 months, is there potential for her to get resistant to AZT? Yeah. Very, very, very possible. Is it possible for her, although she's never in her life taken D4T, to become resistant to D4T? Yes, because AZT and D4T are very similar. Some resistance mutations to AZT confer resistance to D4T. So monotherapy or dual therapy or the PMTCT practices that are not including heart do not benefit the mother in any way. They only provide risk to her. They can develop, because she can develop resistance. Now, if we put her on heart, is that benefiting the mother? Yes. Is it benefiting the child? It is, in both cases, okay? So you must always remember that. When you're, again, everything we do is weighing risks and weighing benefits. But when we are giving these PMTCT interventions, like AZT and nevirapine, that's not treating the mother. It's only treating the child. And there is some risk to the mother. Okay. So women who do not qualify for ARVs in South Africa, we're going to talk about in the new guidelines. And that's the PMTCT interventions. All right. So that's the theory behind it. That's why we do most of what we do. Most of it is involved with reducing the viral load and decreasing the amount of blood-to-blood mixing. All right. Are there any questions about any of that part before we go on to the guidelines themselves? Question?
In terms of the replacement of the tenofovir in exchange for T, why that it's not the same with the second line, since the DDI contains a similar side effects, if that was the case?
Yeah, so I don't know. I don't know why they haven't changed second line. And since tenofovir is available, what do? Is I apply for it. I've applied for tenofovir for use in second line. So people who are on D4T, say standard regimen 1, D4T, 3TC Stokerin, and have failed. Why can't they get tenofovir as second line? Well, to me, there's no reason why they shouldn't. And we should take out the most toxic drug, and that's DDI. So can we do a second line regimen of tenofovir, AZT, Kaletra? Absolutely. And I think that's the best regimen. That is the best regimen. Okay. All right. So as I said, this part of the lecture, that was sort of the meat of it. Beforehand, that was the theory behind what we do. Everything forward is not my own words. I've simply copied directly from the document and pasted it into this lecture. And the purpose of it, I know it's going to be a bit dry, a little bit boring, but the purpose is so you hear it, so you have it. Unfortunately, these guidelines came out on April 1st. Our course started before April 1st. So in the old version of this lecture, the ones that you've had in your handouts, we've printed these binders before these guidelines became available. So the ones that you have in your binders are actually the 2008 guidelines, and what I'm going to be talking about is the new 2010 guidelines, okay? I will give you the website that you can download these, the new guidelines if you like, and also I can try to make copies available of the new PMTCT guidelines, okay? But if you just sit back and pay attention, you'll at least have heard them once from this lecture. Okay? So they cite 4 specific PMTCT interventions in the new 2010 guidelines. Number 1, just like the WHO says, should be primary prevention of HIV. Preventing HIV-negative women from becoming HIV positive. Okay? We should be integrating PMTCT interventions and HIV child care into routine maternal and child health. Now, a lot of these, as I said, are guidelines. They're there. A lot of these are similar to the 2008 guidelines, but a lot of them are not yet put into practice. This is one of them that is not put into practice. This is what's also in the 2008 guidelines. So if we integrate PMTCT interventions into routine maternal and child care, that means all antenatal clinics should be able to provide ARVs, right? Do they? No. No. But if we did, that would integrate these services together. Okay? So I think that's one area where we need to focus on, is getting antenatal clinics trained and access and the right staff and the right environment to start providing ARVs to pregnant women. Because if we're going to integrate PMTCT and HIV and routine maternal child health, that requires ARVs. So that one has been there now for 2 years and hasn't been really put into practice yet. We need to strengthen postnatal care. Okay, we're going to be talking about that again in later in the last part of this lecture. But again, I think that's something that's also lacking in PMTCT services at our antenatal clinics. Because oftentimes postnatal care is just routine postnatal care. We know that children very commonly show up at their 6-week appointment for their 6-week immunizations and they don't receive their PCR test. They don't receive Bactrim if they're HIV exposed. If they do get Bactrim and they do get their PCR drawn, they often don't get their PCR results given to them when that becomes available. So I do think there's still many, many ways that we can strengthen postnatal care. And we should provide an expanded package of PMTCT services. Offer more things, more potential things for these women to prevent infection to their children. And this one is actually increasing. There are now more and more. The new 2008 guidelines have built upon and offered some more things that the 2008 guidelines didn't have. And the 2008 guidelines had some more things and built upon the previous guidelines. So it is an evolving process, and this one, we are always expanding the packages of services to pregnant women. So what are some of these expanded PMTCT services that we need to be providing? And again, remember, I haven't made any of these up. These are directly from the Department of Health. Luckily, and this is one of my favorite changes to the new ARV guidelines for pregnant women. They've finally taken the words voluntary counseling and testing out of the document and changed it to provider-initiated counseling and testing. So no longer does a woman have to ask us, please test me for HIV. It's now us. Every single woman that comes into the antenatal clinic, every single woman that comes to the clinic, we tell her you must test for HIV. There's a risk of your unborn child in getting HIV, so you have to test for HIV. Okay? She can refuse that, but we're urging her, we're insisting that she does do that test. Not waiting for her to come and approach us. Okay? We need to involve the partner and the family in order to ensure comprehensive approach. This statement I like very much. I agree with completely. It was in the 2008 guidelines, and nothing has been done up till now in 2010 to actually put that into practice. Most clinics, most ANC clinics are filled with women. It's very, very rare for a man to come to an antenatal clinic. Right? Am I right? Yeah. So how do we do that? How do we encourage the men to come? How do we give them incentives or do something to get the men involved? Get them talking about HIV, and get them learning about ways that they can assist the woman in preventing the child from getting HIV. But that has not really been put much into practice. All right? We need to provide appropriate regimens to prevent mother-to-child transmission of HIV according to the risk profile based on the HIV test, the CD4 count, and clinical staging. Well, this I also like very well. It's something that I think is improving upon, but it's not done everywhere in the antenatal clinics. What this is telling us, and you're going to see it later in the next few slides, is when you find an HIV-positive pregnant woman, you need to do a CD4 count, you need to clinically stage her, you need to check her for TB, you need to start her on Bactrim. These are all things that we must do as part of routine antenatal care in HIV-positive women. Okay. So, we need to provide other appropriate treatment at these antenatal clinics, such as treatment for opportunistic infections, nutritional support, ARV therapy, depending on CD4 count, nutritional status, and clinical stage. This same exact sentence was in the 2008 guidelines. So take a look at that sentence, take it apart, and what does that mean? It means the ANC clinics should have the formulary in their pharmacy to provide treatment for opportunistic infections. Many of them do not. Many of them do not. They don't have access to fluconazole. They don't have access to acyclovir. Some of them may not have access to TB treatment. All of these are opportunistic infections that it is saying in the document now for 2 years must be available at the antenatal clinic. Not only the opportunistic infections, but look, I'm not making it up, word for word from the Department of Health. It says antiretroviral therapy. This means the ANC clinics should be able to provide ARVs. Again, that's not happening. We should be providing psychosocial support for HIV-positive pregnant women. Very much an important issue. But oftentimes, again, at the clinics, there's not a social worker. There's not a psychologist. The counselors are busy. Maybe the counselors are doing pill counts. They can't bother with doing counseling of the woman. So we need to make sure that these services are available in the ANC clinic. We need to provide quality, objective, individualized counseling on safe infant feeding practices for HIV-positive women in health facilities, offering ANC services through trained feeding lay counselors and healthcare professionals. Well, I hope this is being done. I hope that the counselors, whenever they find a pregnant woman, they counsel her on HIV, counsel her on proper infant feeding practices, telling her what the risks are, telling her what the benefits are, supporting her decision, and giving her the right to have an informed decision about how she's going to feed her child. As we're going to talk about in the next lecture, breastfeeding is not for every HIV-positive woman, and formula feeding is not for every HIV-positive woman. There are risks and benefits to each, and it's an individualized decision. When we find a pregnant woman, we need to discuss these risks and benefits with her, and we can come up together in making a proper decision. What I often find is when I find a pregnant HIV-positive woman who comes to my clinic and I'm ready to start her on ARVs, nobody has discussed this with her. Often it's me that does that discussion. Now, it should be done at the antenatal clinic through a lay counselor who's trained in infant feeding practices. We need to strengthen obstetric practices which reduce PMTCT. We talked about those in the beginning. Okay. We need to improve follow-up care for HIV-positive women and their infants. This I very much agree with. This is, again, a statement that was in the 2008 guidelines. And so it's been in there for 2 years, but it's not been in practice for 2 years. This means that you have to have at your clinic, at an antenatal clinic, a practice, a procedure to follow up on the CD4 count, to follow up on the PCR that was drawn. The procedure for follow-up is not waiting until that woman comes back to the clinic. That's most clinics' procedure. So if a child comes to the clinic at 6 weeks, gets their PCR drawn, that PCR is positive, that result gets delivered to the clinic, we know that that child is HIV positive, when does that mother get the result? When she returns. What if she doesn't return? She never gets the result. That's not strengthening and supporting follow-up care of HIV-positive pregnant women and their child. But that's the practice in South Africa. That's the practice at the antenatal clinics. We don't have a system involved that's functioning to give people their CD4 counts, to give people their PCR results without them coming on their own to the clinic. Okay? It's not very difficult to do. You make a phone call. You have somebody visit their home. Tell them to come to the clinic. Or deliver the results to them, to their home. That's not very difficult to do. Encouraging and supporting safe infant feeding, we talked about. Okay? Providing infant formula for at least 6 months for women who meet the AFASS criteria and who opt to exclusively formula feed. We're going to talk about what the AFASS criteria is in the next lecture. But how many people, how many clinics here who are represented here, their clinic offers formula to pregnant women for 6 months? Put your hands up, I want to see. Okay. We need to provide nutritional counseling and support for women who choose to exclusively breastfeed. Okay. So those women also need nutritional support because they need extra calories, extra nutrition to maintain their own health. Okay. Integrating the follow-up of infants born to HIV-positive women into routine health services and the IMCI strategy. This means that if you're at a local clinic and you're IMCI trained, you should be doing the PCRs, right? You should be asking children who come in to their regular routine visits about their HIV status, if they're exposed to HIV. Most places this is not being done. Children are not asked, the parents are not asked their HIV status, and we're not evaluating the child's exposure to HIV. Past the 6-week visit, children are not asked about their PCR anymore. If a child missed his 6-week visit, it's not common for somebody to say, oh, is the mother positive? Do we need to do this PCR? What's the result if it was done? It's not done. Early infant HIV testing using HIV PCR at 6 weeks of age, integrating with the routine 6-week visit, irrespective of feeding option. So every child should have a 6-week PCR, whether they're breastfeeding or formula feeding, if they're HIV exposed. A repeat HIV test for HIV negative infants at 6 weeks after breastfeeding. This is another one that is missed very, very commonly. A child who comes at the 6-week visit, gets their PCR drawn, they come back for their results, they're told that their child is HIV negative. And that's the end of the story. They do not ask, are you still breastfeeding? Okay, because if you are still breastfeeding, then we need to repeat this PCR. The child is not necessarily negative. The child was negative at 6 weeks, but there's an ongoing risk, an ongoing exposure to HIV that the child needs to be checked again. So that must be improved upon, and when the child finishes breastfeeding 6 weeks later, needs another PCR. So the South African Department of Health has found 4 stages of PMTCT, where each stage we can offer some sort of intervention to prevent infection of the child. So of course there's primary prevention of HIV, the first thing. Okay, using condoms. preventing HIV negative women from becoming positive. If we do that, then less children will become HIV infected. If less women are becoming positive, less children will be becoming positive. Then there's, so the primary prevention. The goal is obviously to reduce the prevalence of HIV among women of childbearing age. The objectives are to implement targeted HIV prevention programs for women of childbearing age, to strengthen prevention of unintended pregnancies among women living with HIV by asking them about contraception, oral contraception, or injectables, and using condoms. Support the implementation of women empowerment programs, and fight against gender-based violence. These are taken again word for word from the 2008 guidelines. And as I said in 2008, that this last point is extremely important. Extremely important. Women empowerment programs, protecting women against violence, is crucial in protecting them from HIV. But is the government doing this? I don't know of any government program that is addressing this issue, but it's been in the guidelines now for 2 years. They mention it on paper. They say it's a great thing that we need to do, but they don't give us funding to do it. They don't give us programs to do it. So most clinics need to take it upon themselves. The counselors become involved. The social workers become involved. The psychologists become involved. The doctors, the nurses, everyone needs to focus on some of these problems, because it's probably not going to come from higher up. And then antenatal. There's many things that we can do to prevent HIV infection. So antenatal care, we can improve the quality of the mother's health and prevent mortality. Identify women who are HIV positive. As I said, we're moving from voluntary counseling and testing to provider-initiated counseling and testing. We should be encouraging all pregnant women to test for HIV repeatedly. If they refuse, they should still get counseling, and then the next time they come, we again encourage them to test for HIV every single time that they come to the clinic. Ensure that HIV-positive women enter a PMTCT program. Prevent mother-to-child transmission. Provide AZT starting, now it used to be at 28 weeks. The 2008 guidelines said we should start providing AZT at 28 weeks. The new guidelines say starting at 14 weeks of pregnancy. So those are for women who don't qualify for ARVs and have a high CD4 over 350. For those that have a CD4 less than 350, we should be starting lifelong heart as soon as possible, obviously depending on her clinical indications, her CD4, her clinical status. We should encourage the involvement of the family, the partner, okay, and other members of the family. Other children, have the other children been tested for HIV? Are there other family members at home who are untested? We should encourage them all to become tested for HIV. Provide individual psychosocial support from the counselors, from the social worker, from psychologists. Screen HIV-positive women for TB. Heart for pregnant women who qualify, other relevant non-HIV services, safe infant feeding counseling, and nutritional support. So at enrollment, this is taken word for word from the new document. This is the new document. So at enrollment, all pregnant women, so this is not just HIV-positive women, all pregnant women should be encouraged to book early into ANC care when they're thought to be pregnant. They should receive routine antenatal care, including micronutrient supplementation, offered information about PMTCT services, offered routine HIV counseling and testing, and encourage partner or spouse testing. This is new to the 2010 guidelines, and I like it very much. We should not only encourage the woman to test, but but we should be encouraging her partner to test. Okay, the men need to also be tested. We need to be counseling on safer sex practices, on the use of condoms. Be counseled on safe infant feeding practices in HIV positive and HIV negative women. Okay, be supported in the choice of infant feeding practices. So that was for all women. Now, HIV positive women, we should be offering these things. Of course, routine ANC care, including iron and folate supplementation, information about what PMTCT services are available. They should be clinically staged, should have a CD4 count on the same day as the HIV test is done, preferably at the first ANC clinic visit. This means that all ANC clinics, if they're open 7 days a week, that means 7 days a week they should have the capacity to draw blood. It means 7 days a week they should have the capacity to send off that blood for CD4 count. Most clinics do not have that capacity. I know most ANC clinics usually draw blood maybe 2 or 3 days a week. But this is saying that if you can do an HIV test, you should be able to do a CD4 on the same day. You should be able to screen for TB on the same day. Okay. Again, as I said, screened for TB the same day. They should be screened and treated for syphilis, for other STIs on the same day. If her CD4 count is less than 350, she should be offered full heart therapy. She should be offered PCP and TB prevention prophylaxis. So she should be provided Bactrim if her CD4 count is low, and if she qualifies, she should be provided isoniazid prevention therapy for TB. She should be counseled on safer sex, family planning, postnatal contraception, and partner testing. So HIV negative women, we sort of talked about already. So HIV negative pregnant women or women who don't know their status should receive post-test counseling, counseling on risk reduction interventions, focus mainly on how to maintain their HIV negative status. Okay, and will continue throughout antenatal care. They should have a repeat HIV test at or around 34 weeks. So even if they tested negative in the beginning of pregnancy, they should test again at 34 weeks. Why should we test again at or before 34 weeks? Because if she's positive now, we know that that means she was acutely infected. And we can offer her services that can reduce the risk of passing the infection on to the child. Women who choose not to be tested should be offered voluntary HIV testing at every subsequent visit. So every time they come to the clinic, if they've refused in the past, does not mean they will continue to refuse forever. They should be offered it again and again and again. Unbooked women who report in labor should be offered voluntary counseling and testing for HIV in the first stage of labor and offered a PMTCT intervention if found positive. So even if they come in labor, it's not too late to do an HIV test. So the new guidelines of provider-initiated counseling and testing has used this graph. So they should have a group information session, which used to be called group counseling. Individual information session, each woman is offered to test. If she agrees to tests and test negative, she gets post-test counseling, and again she should be tested again at or around 34 weeks. If she tests positive, she gets another test to confirm, a confirmatory HIV test. If it's positive, we should do a CD4 count the same day. We should do TB screening the same day. She should be clinically staged that same day. She should receive Bactrim. She should receive multivitamins. If she refuses to test, she gets post-test counseling, and at every subsequent visit, she continues with provider-initiated counseling. So at the first visit, these are the 5 things, again, taken directly from the document that must be done. A CD4 cell count taken, HIV clinical staging, screening for STIs, screening for TB, checking the LFTs, and initiating ARV prophylaxis or treatment. Take a second for that to sink in. Number 5 says at her first visit, the first time you ever see this woman, the first time she's found pregnant, the first time we do an HIV test, she leaves that clinic with ARVs. Either as prophylaxis, so AZT, if we don't know her CD4 count. If we do know her CD4 count, she's been known to be positive and now is pregnant and it's less than 350, she leaves the first visit with ARVs. That's what the guidelines say. I'm not making this up. You can see that this box is white because I've cut and pasted directly from the document. I didn't even type it in. That's what the document says. And when should the women come back for their CD4 count? So after that first visit, we do all those things, those 5 things that we just said. We did our CD4. When should she come back for her results? 1 week. 1 week. This is again taken directly from the guidelines. The result must be given to the woman within 1 week. Lab turnaround for CD4 count should be less than 1 week. I think somebody needs to pass these guidelines on to Albert Latuli and the labs that we're using, because most of them are not available within 1 week. Even pushing 2 weeks. Recently, it's been taking much longer, 3-4 weeks, to even get the results on the intranet. Okay? So these guidelines, I think, need to be forwarded on to the people doing the labs. And if they're going to put this in the guidelines, then they need to enforce it. If enforce it means they need to put more money into training more staff, having more machines, having more facilities do CD4 count, so be it. They've put this into the document. They should be enforcing it. Okay? Each facility should have a mechanism in place to follow up on CD4 count from the lab, discuss the results, and I've highlighted this in red because this is not done anywhere that I know of. Trace women who do not return for results. Word for word from the guidelines. It means your clinic needs to start doing this. When a woman does not pitch up after that 1 week, when you got your CD4 count result back, you trace her. Give her a phone call. Have somebody go to her home. Whatever you do to trace her needs to be done. She needs to be given that CD4 count result. The same is true, and we'll talk about at the end of this lecture, for PCR results. Okay? We need to trace them, come up with a mechanism to trace those results. Give them, deliver the results to the patient. And this is saying within 1 week. So, using ARVs in the antenatal clinic. Most clinics do not have access to antenatal care, but this is what, taken again directly from the document. So, this is the flow sheet. So, she books at ANC. We case find by doing our rapid tests. HIV positive women, if 14 weeks gestation, a registered health professional prescribes AZT and does a CD4. So this is at the first visit. She tested positive. If she's after 14 weeks, she leaves the clinic that very same day with AZT. We don't know her CD4 count, but she leaves the clinic with AZT. When we get the CD4 result, which is supposed to be 1 week. If she doesn't pitch up in 1 week, we trace her. So as soon as we can, we get that result to her. If her CD4 count is, that should say over 350 now, over 350 or unknown, she continues AZT. If it's less than 350 or she's stage 4, she continues AZT, and we prioritize to start ARVs. Okay. So if she qualifies, she continues AZT until the day that she starts ARVs, which should be within 2 weeks. Okay. So when do we start? So this is TB, women who are found to be TB positive, pregnant, and HIV positive. These are the new guidelines. This has changed. Okay. So if her CD4 count is over 250, she starts ART only after the patient has stabilized on TB treatment. So somewhere between 2 and 8 weeks after starting treatment. And initiate ART from 12 weeks gestation onwards. So she has a high CD4 count. It's over 250. She's on TB treatment. Okay, we know that there's drug-drug interactions between them. Okay. We know that there's potential side effects. So we start the TB treatment first. If she's okay, somewhere between 2 and 8 weeks, she needs to start ARVs. If her CD4 count is less than 250, we start ARVs only after the patient has stabilized on TB treatment, 2 to 8 weeks after starting treatment. Usually, that is about 2 weeks. It should be about 2 weeks. Because the longer the woman is on HART, the lower her viral load, and the less likely she will pass the infection on to the child. Okay? So it doesn't matter on the gestational age of the child at that point. If severe morbidity or very low CD4 count, less than 50, we start ARVs after 2 weeks of TB treatment. Pregnant women who develop TB while on ARVs should continue their existing ARV regimen unless they're taking Kaletra or Alluvia. In that case, that dose should be doubled. So if they're taking Alluvia, the dose of the Alluvia should be doubled. Okay. Anemia. We need to be screening these women for anemia. If the hemoglobin is less than 7, we don't start AZT immediately. We should investigate for causes of anemia. If the hemoglobin is between 7 and 10, she can take AZT, but she should be given iron supplementation. Okay? And it should be given 3 times per day. We should repeat the hemoglobin in 2 to 4 weeks if there's no response or the hemoglobin is dropping. They continue AZT, but urgently refer the woman to a doctor to investigate causes of the anemia. If the hemoglobin is 10, she can continue AZT, and we usually give ferrous twice a day. Recheck the hemoglobin after 4 weeks on AZT. So we need to be monitoring pregnant women on AZT even before they take AZT with their hemoglobin. Infant, this is a bit out of place, but the infant dose of nevirapine is there. You can just refer to it. If they're less than 2.5 kilograms, it's 10 milligrams. If it's higher, it's 15 kilograms. What to do about abandoned infants? So abandoned infants should receive nevirapine as soon as possible, less than 72 hours after birth, and continued until HIV exposure status has been determined using a rapid test or an HIV ELISA test. If the infant has been HIV exposed, meaning the rapid test is positive, nevirapine should continue until 6 weeks of age and followed by PCR at 6 weeks. If maternal status is unknown, so we don't know the maternal status, the mother has died or the mother never wanted to test, this includes cases in which the mother is indisposed, she's too sick, she's in ICU, she's somewhere else. the infant should receive nevirapine and have an HIV test, ELISA or rapid test, to inform further management of the child. Take a minute for that to sink in. If the mother's not there, the child can still be tested for HIV. You do not have permission from the mother. You don't know the status of the mother. You can test the child. Okay. Where the mother is known to be HIV positive, but she refuses any ARV prophylaxis for the child. So the mother's positive, but she doesn't want to take nevirapine herself, and she doesn't want anything for the child. A counselor must intervene to explain the risk of mother-to-child transmission and benefits of ARV therapy. Should this counseling fail, so you've counseled her, you've told her the risk, there's a risk of your child getting HIV, and she says, I don't care. Don't give anything to my child. Then, the healthcare worker should consult the head of the facility and with his or her permission, provide necessary treatment in the best interest of the infant. In all actions concerning children, the best interest of the child shall be of primary consideration. They've cited the Children's Act, number 38 of 2005. This says, whatever we do, we must act in the child's best interest. If the mother is refusing treatment for the child, we can still give it to the child. In the child's best interest. Against the mother's wishes.
What happens after discharge?
What's that?
What happens
After
after discharge?
discharge, you can't force them to take it, but you could keep the child hospitalized. You could even offer them a few doses of nevirapine in the hospital, which will reduce their risk of getting HIV. This also means, against the mother's will, you say, I think we should test this child for HIV. And she says no. What does the Child Health Act say we do? Act in the benefit of the child. So can we test the child? Yes. Against the mother's wishes? Yes. Right here, says so. I didn't make this up. Again, I've copied this directly from the document. So that was antenatal care. What about during labor and delivery? So, of course, even if during labor and delivery, if the woman is unbooked, we can still identify cases. We can still test her for HIV if she doesn't know her status. We could provide adequate PMTCT coverage. We can still, even at this very late stage, offer interventions to prevent infection of that child. Continuity of care and prophylactic treatment of ARVs, reduce maternal nevirapine resistance, initiate neonates born to HIV-positive mothers with ARV prophylaxis immediately after birth. So ARVs during labor and delivery. We talked about beforehand, now this is during labor and delivery. So we identified the mother. She gets, once labor starts, she takes her nevirapine dose. Okay, a one-time dose. She should be administered AZT according to the relevant legislation, which is the current one, is every 3 hours during labor. So every 3 hours during labor, she receives AZT. Okay. Then she delivers, and the mother gets regular follow-up, and the child gets single-dose nevirapine immediately after birth, and nevirapine for 6 weeks. This is new to the guidelines. No longer are we using AZT for the child. There used to be 28 days of AZT versus 7 days of AZT, blah, blah, blah. All that is finished. It's the child gets 6 weeks of nevirapine. These are the different ARV strategies and dosing guides for all the different scenarios. So if a woman is eligible for heart, her CD4 is less than 350, she's WHO clinical stage 3 or stage 4, she initiates with tenofovir 3TC, or FTC and nevirapine. Okay. And that's to start lifelong heart, and it says within 2 weeks. So if you find a woman with a CD4 count less than 350, or she's stage 3 or stage 4 and she's pregnant, then she starts lifelong therapy within 2 weeks. If she's already on ARVs, she's already on heart, then she continues. Okay. If she's less than 12 weeks pregnant, we substitute efavirenz for nevirapine. So we'll switch her efavirenz for nevirapine. If she has a contraindication to tenofovir, so which usually means kidney disease, then we substitute tenofovir, we substitute AZT. So then AZT, 3TC, nevirapine is the regimen of choice. If she's not eligible for heart, so her CD4 count is over 350, she's WHO stage 1 or 2, then she takes AZT from 14 weeks. She takes single dose nevirapine at the onset of labor and AZT every 3 hours during labor. And then, this is again new to these new guidelines, she takes a single dose of Truvada, which is the brand name of the combination of tenofovir and FTC, as a single dose stat after delivery. This reduces the mother's risk of developing resistance to nevirapine. So the single dose of this medicine reduces that risk. This medicine's half-life is 24 hours, so she reduces the risk of developing nevirapine resistance by taking these additional medicines. If you don't have Truvada available, which I'm not sure that most places do actually, then she takes 300 milligrams of tenofovir plus 300 milligrams of 3TC. Okay, you can substitute 3TC for FTC and just give the full day's dose together, so 2 of the 150 milligram tablets. If a woman presents unbooked and presents in labor, she takes single dose nevirapine plus AZT every 3 hours in labor, and again takes a single dose of Truvada, which is a combination tenofovir and FTC. If FTC is not available, she takes tenofovir plus 2 tablets of 3TC. And then assess maternal ART eligibility before discharge, which means she should have her CD4 checked. She should be clinically staged. She should be checked for TB. Okay, so that's for the mother. What about for the child? If the mother is already on lifelong heart, the child still takes nevirapine at birth and then nevirapine daily for 6 weeks, irrespective of infant feeding choice. Whether the child is infant feeding or formula feeding, they still take nevirapine daily for 6 weeks. If the mother was only on PMTCT regimen, so she was only on AZT, then the child takes nevirapine at birth, then daily for 6 weeks, and it's continued as long as the child is breastfeeding. Okay? And formula-fed baby can stop nevirapine at 6 weeks. If the mother did not get any ARVs during the delivery, so she was unbooked or she didn't receive anything at all, the child gets nevirapine as soon as possible, daily for 6 weeks, and continued as long as there's any breastfeeding. And of course, the child should be assessed for ART eligibility for the mother, within 2 weeks. If we don't know the status because of orphaned or abandoned child, the child gets nevirapine immediately. Test the infant with the HIV rapid test. Doesn't say you need to get permission from anyone, you just test the child. If positive, the child continues for 6 weeks. That test is not testing the child, it's testing the mother. The rapid test only tells us if the child was exposed to HIV. If it's positive, we know the child was exposed to HIV, so that child continues nevirapine for 6 weeks. If that rapid test is negative, then the child was not exposed to HIV, and the child does not need nevirapine. What about after labor? So we should assist with feeding options. We should register the birth, of course. And immediately after birth, within 1 hour of delivery, all infants born to HIV-positive women should ideally receive skin-to-skin contact with their mothers, regardless of the mother's feeding choice, formula-fed or breastfed. All infants should start feeding exclusive breastfeeding on demand or exclusive formula feeding. This should be their choice, either exclusive formula feeding or exclusive breastfeeding. We should counsel against mixed feeding. We're going to talk about that again at the next lecture. If the mother has not made a decision about feeding yet, she should be counseled on infant feeding and ASS be determined. We're going to talk about what that means at the next lecture. So what can we do postnatally? We talked about primary prevention. We talked about A and C care during labor and delivery. What about after birth? Postnatally, provide follow-up postpartum, including postnatal visit, within 3 days. Within 3 days, the mother and child should be followed up. Improve the quality of the mother's health and reduce mortality by including family planning counseling and cervical cancer screening where applicable. This means postnatally, women should be getting pap smears done. Should be talking about preventing future pregnancy if she wants to. What is she doing to prevent pregnancy? Provide post-exposure prophylaxis to infants. That's the nevirapine for the child. Reduce postnatal HIV transmission through breastfeeding. Identify all HIV-exposed infants. Reduce mortality in HIV-exposed infants. And identify all HIV-positive infants. And start ART early. So what do we do? We're going to see this again during the infant feeding lecture next, but what do we do with exclusively formula-fed children? Well, first we identify an HIV-exposed infant. At 6 weeks, at their routine visit, at their routine immunization visit, we start cotrimoxazole, we start Bactrim. We do a PCR. We discontinue infant nevirapine if the child is formula feeding. Okay. Safe infant feeding, counseling and support. Remember, this is for formula-fed children. If that 6 weeks PCR is negative, then we stop cotrimoxazole and the child should have a rapid test at 18 months. If that's negative, the child is confirmed negative. If the PCR is positive, that child is referred for prompt ART and continues cotrimoxazole. Remember, any HIV-positive child qualifies for ARVs in South Africa within the first year. So this child at 6 weeks of age will qualify for ARVs. We should start them as soon as possible. We don't need to wait for the CD4 result. We don't need to wait for baseline bloods. This child needs to start ARVs. So the day that they get their PCR result, that child could start ARVs. We should confirm the status with a viral load. When you're drawing baseline blood, it is very helpful in infants to draw a CD4 and viral load, because that viral load will serve as a confirmatory test for that child. If the child has an undetectable viral load, well, then something's strange, because the child should have a very high viral load. So then maybe you need to repeat the PCR. Mothers who exclusively breastfed children and mothers on ARVs. So if we find the infant exposed to HIV, again, 6-week visit, everything stays the same. If the PCR is negative, the mother needs to continue exclusive breastfeeding for 6 months, continue cotrimoxazole until breastfeeding is stopped, and infant negative repeat HIV test 6 weeks after stopping breastfeeding, and a rapid test at 18 months of age. If all that's negative, stop the Bactrim. If the PCR is positive, they should be promptly referred for ARVs. Remember, the child automatically qualifies for ARVs. We don't need a CD4. We don't need any baseline blood. We know the child qualifies for treatment. Confirm the status with a viral load. Continue breastfeeding for 2 years. And continue infant cotrimoxazole. So if we find the child positive at 6 weeks and they're breastfeeding, we should encourage the mother to continue breastfeeding for up to 2 years. Exclusively breastfed children for mothers who are not yet on ARVs. So that was for mothers who were on ARVs. Again, the 6 weeks visit, they get cotrimoxazole, they get their PCR done, and the child continues infant nevirapine. If the PCR is negative, they continue exclusive breastfeeding for 6 months. We continue nevirapine until breastfeeding has stopped, continue cotrimoxazole until breastfeeding is stopped, and infant is confirmed negative. We repeat the PCR 6 weeks after stopping breastfeeding. If it's negative, then we stop cotrimoxazole. We do a confirmatory rapid test at 18 months. If it's positive, either at 6 weeks or at the repeat, the same thing is true. We do a prompt referral for ARVs. The child automatically qualifies for treatment. We confirm the status with a viral load, continue breastfeeding for 2 years, continue infant cotrimoxazole, and stop the infant nevirapine once the child starts on ARVs. Okay. I'm going to skip that one. It's actually not in the guidelines anymore. Children not identified through PMTCT. Immunization visits up to 14 weeks of age should be used to identify babies whose mothers are of HIV unknown status. Okay. So if the mother did not go through PMTCT, if we didn't identify the child that way, we need to identify the child anyway. Now the guidelines say up to 14 weeks, but it doesn't matter how old the child is. If the mother did not go through PMTCT, if the status of the child is unknown, if the status of the mother is unknown, we need to start identifying the children. All opportunities should be used to diagnose HIV in infants who display relevant signs and symptoms. That's what the guidelines say. Well, I say all opportunities should be taken regardless of signs and symptoms. HIV positive children should be picked up regardless of signs and symptoms. Every child presenting to the clinic, we should try to identify what is their HIV status. Okay? Mothers should always be encouraged to take up an HIV test. Okay? And we should always be looking for the status of the child if we don't know the mother's status. Okay? Any questions? So those were the brand new 2010 guidelines. Took effect 3 weeks ago today.